So, good morning, everyone. Myself, Dr. Suneet Pipre from Capacity Building Division of National Health Authority, and I welcome all of you in today's Nirantar Shiksha session on universal health coverage. And I'm delighted that the senior leadership of National Health Authority has joined this session, as well as we have esteemed delegates and speakers for today's session from World Bank, Mr. Ajay Tandon, who is lead economist in World Bank, and he'll be speaking on UHC today, as well as Ms. Sheena Chabra, specialist, health specialist from World Bank, senior health specialist, and we also have Dr. Sudha, who is executive director in National Health Authority. So, Dr. Sudha will be moderating today's session, and ma'am, over to you.
Thank you, Sunny. A very warm welcome to everyone present here today for this important session. As we are celebrating, we just celebrated the Universal Health Coverage Day on December 12th, and our joint event with the ministry was held on 13th December. So we are still in that mood of, ensuring that the momentum is maintained. So that is why when this session was being planned, we thought it would be very apt to have this as a continuum of the UHC Day celebrations. And I'm very pleased to introduce Sheena Chabra, a senior health specialist with over 30 years of experience, and who's leading as the senior health specialist in health, nutrition, and population and global practice, and supporting the National Health Authority both for technical and advisory support for PMJY scheme. She's also co-leading the National AIDS Control Project and also the Uttarakhand Health System Development Project. So, very warm welcome to you, Sheena. Dr. Ajay has been a colleague and a friend for quite some time now, and he has done his PhD in economics and has been working as a lead economist from the World Bank now, but has had a very long, illustrious career across various organizations, ADB, Harvard University, Oxford, and one of the major thing I remember is his book, Going Universal, how 24 countries are implementing UHCs from bottom up. Mainly because I won that book as a from Somil. Yes, from Somil had to courier it to me because he had asked for some in a workshop that who would respond to something, and I had responded, and he said that you will win this book. So that's how I got that book. So I've read it cover to cover. So I'm very happy that you will be giving that experience to more colleagues and our state health officials who have joined. I do see a lot of states represented today to listen to you and Sheena. So please, over to you, and maybe we will take the questions at the end of the session, and we could see how things go ahead. Over to you, Sheena and Ajay.
Thanks very much, Dr. Sudha. It's really a pleasure, presenting and sharing some of the thoughts that we have related to universal health coverage and what have been some of the global experiences. And what we would also highlight are some of the pathways specifically, for PMJ in terms of UHC. So that's what we are going to share. And with that, I'm going to request Dr. Ajay Tandon to start the presentation, please.
Thanks very much, Dr. Sudha and Sheena, and thank you for this opportunity. So I'm probably going to speak for about maybe 35-40 minutes, and perhaps we can leave out. And I'm going to ask Sheena to come in at the end to also lead some of the discussion. But basically, the title is Universal Health Coverage, Global Experiences and Lessons for India. And I'm going to there'll be three blocks of my presentation. The first is, really on the concept of universal health coverage. Just want to make sure that we are all on the same page. What do we mean by universal health coverage? And I will also give you a highlight of our latest 2021 release of the Global Monitoring Report for Universal Health Coverage. This was released on UHC Day on December 12th. It's jointly done by WHO, World Health Organization, and World Bank. The second block, I'll talk a little bit about global country experiences with universal health coverage. What have some countries done? What are some commonalities? What are some differences? And then ending with some lessons and implications for India as a way to set the stage for discussions. So let me just start with the universal health coverage and the launch of the latest version of our monitoring report for universal health coverage. Let me just make sure that everybody is on the same page with regard to the definition of universal health coverage. So, what really is universal health coverage? See, the objective of universal health coverage is that everybody, and I do mean everybody, should have access to health services that they need, when and where they need them, and without financial hardship. Actually, it's missing a word. It should be access to effective health services they need. So the health services should be of good quality, when and where they need them, and without financial hardship. Now, one point to remember is for those of you who are familiar with other global calls like the Alma Ata, the Millennium Development Goals, and so on and so forth, what makes this call for universal health coverage different from other objectives and initiatives is this recognition that it's not just about getting improvements in service coverage, but also making sure that there's no financial hardship. So the economic consequences of accessing healthcare are co-equally represented in the objective for UHC. Another way to think about it is in the objective of universal health coverage is to make sure that when you get sick, that you recover, but that your wallet doesn't get sick as well. So it's recognizing that how a health system is financed is also very important. And I hope several of you are familiar now with a way to conceptualize and understand universal health coverage. This is called the UHC Cube. For those who may not be completely familiar, I'll just briefly go over the fact that the UHC Cube is about increasing the number of people who have coverage from pooled financing. That is financing that's not out of pocket. So it's financing that's through general taxation or through some kind of insurance, some kind of prepaid pool financing. So the objective is to get more and more people covered with pooled funds. The second objective is to have more and more services covered. So in some cases, initially, maybe only immunization was provided through pooled funds, but over time, you add on other outpatient services, inpatient services. So the objective is not only more and more people get covered, but also more and more services get covered. And the third dimension is that more and more of the cost gets covered. So this is a very simple way to think about what is universal health coverage. The objective is to really expand that blue cube that's in the middle to get more and more coverage to the entire population, to the entire set of services, and to reduce cost sharing at the time and place of seeking care, so that financing is through pooled funds. So again, 3 dimensions: who is covered, what services are covered, and how these services are covered. Are what is encapsulated in this universal health coverage objective. You can also think about universal health coverage as not really being a destination, but a direction. So you're moving the country towards more and more of this happening. Of course, with technology and with other things, the service coverage may always keep going up. You have new medicines that come on board and so on and so forth. And of course, you may not have completely the financing to cover everybody through current pooled funds initially. So, the goal here is to try and move in that direction more and more. And it's not necessary to be viewed just as a destination. A couple of points to note, that this UHC cube way of understanding and defining universal health coverage doesn't directly address quality of services and effectiveness. That is implied that the services that are covered are of good quality to be effective. The UHC cube also does not capture issues related to unmet needs. So the way it's conceptualized, it's just saying what is the current health spending. More and more of that current health spending should come from pooled funds and less from out-of-pocket financing. But of course, you have a certain section of the population that doesn't utilize because they can't afford to utilize, or they're not aware of their health problem. And it's not yet included. It's not conceptualized in the visualization of universal health coverage, although it should be. And also, of course, the UHC cube does not capture the indirect costs of ill health. So usually economists, when they talk about costs of healthcare, the direct cost is, what you pay. Maybe you have to pay user fees, or you have to pay for medicines, or you have to pay the provider. That's called the direct cost. But there are also indirect costs of falling ill. And one typical example of an indirect cost is you're not able to work. And if you're in the informal sector, you are a daily wage earner, there's an opportunity cost, meaning you not only do you have to pay for seeking healthcare, you also have to forego some income. For instance, if you're hospitalized for 5-6 days, that's an indirect cost in terms of not being able to work for those 5 or 6 days. So that's not directly captured, which is not to say that this is wrong. It's just to say that these are additional things to keep in mind, that this is just a conceptual visualization to help us understand better what is universal health coverage, but it's not entirely complete. There are other dimensions that are just as important. So the other point is that universal health coverage is one of the United Nations Sustainable Development Goals for 2030. The Sustainable Development Goals are a set of objectives across different sectors and different dimensions that countries have signed up for, including India. And the universal health coverage is actually part of SDG 3, which is to ensure healthy lives and promote well-being for all ages. There are many different dimensions. Under 5 mortality rate is included. Maternal mortality rate is included. But also one of the targets is universal health coverage. It's an intermediate objective of a health system in that it measures coverage of interventions. So essential, it has 2 dimensions: coverage of essential health services, and it measures the financial hardship when seeking care. Again, a reminder, so universal health coverage gives co-equal status to how you access healthcare or how a health system is financed. So it's not just going to look at coverage of services, but also how much do you have to pay out of pocket. And the goal is to increase coverage as well as to reduce the financial hardship when seeking care. And these are some recommended universal health coverage monitoring tracer and indicators that are summarized in the latest report. This is available online. For those of you who are interested in this, you can go and download it. This was just released, like I said, on December 12th. And the tracer indicators for measuring whether or to what extent a country has made progress towards universal health coverage includes coverage of reproductive, maternal, newborn, child health services. So included as a measure, as one of the measures of making progress towards universal health coverage, is the proportion of those who have access to modern contraceptives, those who have 4 or more antenatal care coverage visits when they're pregnant, DTP3 vaccine coverage rates, care-seeking behavior for pneumonia. It also includes dimensions of infectious disease coverage. To what extent is there TB effective treatment, HIV treatment, the proportion of those sleeping under bed nets in high-risk areas. So this is not for the entire country, but only countries where the risk of malaria is, the regions of the country where the risk of malaria is higher, as well as access to improved sanitation, a key determinant of health. It includes dimensions of non-communicable diseases, blood pressure, fasting plasma glucose, tobacco, smoking, as well as service capacity and access, hospital bed density, health worker density, and also indicators of financial hardship. So what is the proportion of households or individuals in a country that have very high out-of-pocket spending as a share of household budget, for instance, in a given year? And the current benchmark that is used is households that have spent more than 10% of their budget on accessing healthcare in the past year are considered to have suffered what we call catastrophic health spending, very high health spending. This is spending that is better off replaced with prepaid pool financing, because this is taking away from other necessary spending that the households may have to do. And also a second aspect of financial hardship is the proportion of households that are made poor or pushed deeper into poverty as a result of high out-of-pocket spending. I'll elaborate a little bit more on these, but just to say that using these tracer indicators, we sort of do a biannual exercise every 2 years to try and measure how countries have done, to identify which countries have done better than others, to try and understand what is it that could help countries learn from each other in order to make progress. So all of these indicators are put together into one index, but you also have the sub-indices separately to see how and where things have happened. And the other point to note over here is insurance coverage is not a UHC monitoring tracer indicator. So there's nowhere over here the proportion of the population that's covered by insurance. The reason being that insurance is in of itself not a tracer for UHC. Insurance is just a means to an end. Many countries have made progress towards universal health coverage without any kind of social health insurance. So it's not wedded to any particular model. It's agnostic about that part. Of course, the way the health system is financed is captured in the financial hardship indicator. So if we take all these metrics and we separate it into the service coverage metrics versus the financial hardship metrics. So if we take put all the service coverage indicators together, the maximum a country can get is 100% coverage if you look at the report more carefully. And just to make the point that the latest estimates we have are usually with T-2. So this was just before COVID-19 hit. And India has made progress. It's moved up to 61 from 55. And what that basically means is on average, there is 61% coverage for all those indicators that I mentioned earlier on non-communicable diseases, on antenatal care, and the other dimensions of service coverage. And if you compare, you can see India has done better than say Pakistan and Nepal and Bangladesh. It's done worse if you compare it to China, or if you compare it to Thailand. It's doing better compared to Indonesia and to the Philippines, so it's just to also give you a relative sense. And of course, you can do the same exercise by state level if you want to try and see, and you'll probably see big differences within the country. So India's done well, but there's room for improvement. It could do much more. But of course, there are many parts of the world that are still struggling. Most of sub-Saharan Africa does very poorly. Some elements, other countries in South Asia and also in Southeast Asia, much more can be done globally in order to make progress towards this service coverage dimension of universal health coverage. Now, you can also see in India's case, what is it that helped India make progress, and where is it still lagging? So what I've done is I've just plotted the indicators. The big thick red line over here is the average for service coverage for India. We are at 61 now at 2019, and then the different components. So you have the family planning immunization components here. This is reproductive RMNCH services in gray. You have NCDs in the orange. You have the capacity of the health system in green, and you have infectious disease in purple. And you can clearly see, I think the most progress that India has made has been in infectious diseases. It's doing quite well in RMNCH. And a large reason for this is the success of programs such as the National Health Mission that have really helped improve RMNCH. Where India has made less progress is really on NCD coverage, and there India is not alone. I think many countries are lagging in terms of NCD coverage. I've just pulled out some of the latest data from the NFHS 5 that was just released, I think, last month. So India, on average, for women who are pregnant, about 58% of them have 4 or more visits that are recommended by Ministry of Health. Impressive levels of skilled birth attendance, almost 90% skilled birth attendance, almost 90% institutional delivery rates, much higher than neighboring countries and comparator countries, but relatively poor, for instance, in terms of screening for NCDs. Only 2% had screening for cervical cancer. And for instance, only about 11% of men who have hypertension had hypertension controlled, or that they were aware of having it, had treatment for hypertension, and that hypertension was controlled. So sort of you can get a sense as to where more improvements need to be made or where things have improved, just to give you a snapshot and with more granularity. And again, just to make the point that these are just recommended indicators by WHO and World Bank. There's nothing that stops a country from adding additional relevant indicators in order to try and assess progress towards universal health coverage. Just another point, and is that globally we are expecting that as a result of COVID-19, service coverage levels will plateau or even decline in many countries, including in India. So this is sort of giving you the global average, and we have some preliminary estimates that because of COVID-19, because of the lockdown, because of fear of utilizing at health facilities, voluntary social distancing, a lot of countries globally have faced a sort of a decline in service coverage. Hopefully that is temporary and will get reversed again, but we expect to go through a bumpy period where years of progress on service coverage for universal health coverage might get reversed or get slowed down. And as and when more data become available, we are capturing that and updating globally what's happening. I was talking now about the service coverage part of universal health coverage. Let me just briefly talk a little bit about the financial hardship part of universal coverage, and how do you measure financial hardship. If you remember, the two indicators that we use are what proportion of households have very high share of out-of-pocket spending in their budget, and then how many households are either pushed into poverty or pushed deeper into poverty as a result of out-of-pocket spending for health. Just a very simple example. If people are not able to follow this, please follow up with me by email. But this is just showing you, this line is just showing you households in the country ranked by how much their consumption is in a given year, for instance. So you have some households who are below the poverty line, and then others above the poverty line. And so this is showing you the level of consumption expenditure, household consumption expenditure. And then, not everybody falls sick, but among those who fall sick, you may have out-of-pocket spending. As long as your out-of-pocket spending is less than 10% of your household consumption or household budget. We consider that to be okay, no financial hardship. But if you're a household that spent more than 10% of your household expenditure in a given year, that's considered to be a household that's faced catastrophic expenditure. So the proportion of those households facing more than 10% is included in the metric of catastrophic expenditure incidence. The other part is that even if you have less than 10% expenditure, you may be just near poor, and your expenditure and out of pocket maybe only 5% or only 2%, but you're pushed below poverty. And any out of pocket spending, if you're already poor, is considered to be either impoverishing or being pushed deeper into poverty. So let me just repeat 2 dimensions. One dimension of measuring financial hardship is you just find out what is the proportion of households in a country in a given year that spend more than 10% of their budget on out-of-pocket spending for health. So you just add up all those households, divide by the total number of households in the country, and that gives you a metric of how much is the incidence of what we call catastrophic health spending. But in addition to that, we say, well, for the poor and near poor, even 10% is quite high. So we add even those who are near poor or non-poor, those who are near poor and poor, even less than 10% of spending out of pocket on health can push you into poverty or push you deeper into poverty. And that's also considered to be a bad metric that shows you that financial hardship is high in a country. And these are the latest numbers for the world. You can see India's case, about 15 to 20% of households spend more than 10% out-of-pocket spending on health in India. And in terms of impoverishment, also India is about 20 to 30%. Remember, anybody who's poor, and even if they spend 1% on out of pocket, that's considered to be further impoverishment. So in terms of financial hardship, India does less well compared to service coverage. So more room to improve. And that's common across many developing countries, that we see very high levels of out-of-pocket spending and impoverishment. The global headline message is that even before COVID-19 pandemic struck, this is globally, this is not just India, about 996 million people in the world faced household out-of-pocket spending that was more than 10% of their budget. And in addition, about 435 million people were pushed further into extreme poverty. This is those living on $1.90 per day. And then 70 million people were pushed into extreme poverty. So these were near poor people who were pushed into poverty. This is people who were already poor and had to pay out-of-pocket spending. This is really anybody who faced 10% or more of their household budget on paying for healthcare. So unlike the service coverage dimension, where the world has been making progress, in terms of financial hardship, actually the world was moving in the wrong direction. So the incidence of financial hardship has actually been increasing globally. And so again, reiterating the point that the way you finance the health system matters. And here you can take a look for India's case. I've just taken the last 20 years of data, and you can see what has been the annual change in public spending on health over the past 20 years versus the annual change in out-of-pocket spending for health. And in India's case, out-of-pocket spending remains the largest source of financing for the health sector. More than half of all financing comes from out-of-pocket sources. And although public financing has been increasing at a faster rate than out-of-pocket spending, it's not been fast enough to crowd out out-of-pocket spending, unlike the case, say, for instance, in Thailand, where your public financing has grown a lot and then out-of-pocket spending has actually been declining. So in India's case, both have been increasing, even though public financing has increased slightly higher rate than out-of-pocket spending, not enough to really change. And more than half of health financing in India continues to come from out-of-pocket spending sources. And one reason for that is because the public spending on health is relatively low. It's in the range of 1 to 1.2% of GDP. It's one among the lowest in the world. And globally, there's a very negative relationship between what is public spending on health as a share of GDP and how much is out-of-pocket spending in the health system. So you can see countries like Egypt, Nepal, Pakistan, Nigeria, Bangladesh, Myanmar, all of them have very high out-of-pocket spending for health, very low public financing for health. And in addition, just we are getting indications, just like in the service coverage dimension, we're getting indications from data that service coverage improvements are plateauing or going to get reversed. We're also getting indications as a result of COVID-19 that global extreme poverty for the first time in several decades is going to increase rather than continue to decrease. So as a result of greater impoverishment, that means any out-of-pocket spending that people pay when they're poor shows that you have financial hardship. And then the World Bank has been doing some rapid surveys, and increasingly we're seeing across low income, lower middle income countries that households are reporting affordability as the main reason for not accessing healthcare. So even if out-of-pocket spending levels are the same, because incomes have gone down, so capacity to pay of households has gone down, creating more financial barriers to accessing care. So we are going to see an increase in financial hardship as a result of COVID-19. I'm going to switch gears a little bit and just also give you a flavor that, this first part was really to just give you where the world is in terms of universal health coverage. How do you measure universal health coverage? What is universal health coverage? I'll just briefly go over some country experiences with universal health coverage before ending to give you a sense of what might be some lessons and implications for India. As I pointed out earlier, public financing is key for universal health coverage. By public financing, I mean either general taxation financing. General taxation financing means people pay taxes. Those taxes go into the government budget, and then the government budget is used to either provide health services or buy health services from private providers. You also have the option in health to have what we call social health insurance. In social health insurance, basically, it's not a general tax, but it's more a mandatory earmarked income tax that you pay that typically goes into a quasi-public agency, a social health insurance fund, which is then used to buy services from both public and private providers. These are sort of two theoretical extremes. One model is called general taxation. The other model is called social health insurance. Reality is often more like the third model here, in that you end up having multiple contributions. So you have taxes contributing. So typically, a very typical country, a developing country model is you have the formal sector, you have the poor, and then you have the informal sector, the non-poor. They're paying taxes, but those taxes then are used as prepayment to pay for the poor. And then you end up having a social health insurance fund, which is or several funds which provide coverage for different sections of the population. I'll come back to this point a little bit to just show that, that the real world never is an extreme case of general taxation or social health insurance. Many times you have combinations, including in the case of India. Just a couple of headline examples. So if you take a look at countries like Indonesia, Vietnam, Philippines, Turkey, they used to have different schemes for covering different populations. So they used to have contributory schemes, where by contributory means that you have to contribute, mandatory contribution taken out of your payroll tax. Then you had non-contributory schemes where covering the poor, where the premiums were paid by the government. The poor didn't have to contribute. Many of them have combined all these schemes into one single umbrella to provide coverage to a larger share of the population.
Yes, thank you.
Thank you. You have other countries like Kyrgyz Republic and Armenia, where they actually don't, where they have universal access to everybody for primary care, but the inpatient care access is only provided for the poor, and the well-off pay inpatient care out of pocket. So they kind of have a benefits package which is different depending on your economic status. You have neighboring countries like Sri Lanka and Malaysia that have general taxation financing. They have universal access to a fairly strong public system, but then you have out-of-pocket spending, usually that the well-off end up accessing private systems using out-of-pocket. But the basic foundation is a very strong tax-financed system. In Thailand, you have separate contributory and non-contributory schemes administered by different agencies and ministries. In Thailand, everybody who's in the informal sector, whether you're poor or non-poor, you're covered with the tax-financed non-contributory scheme. The contributory schemes are separate for those who are civil servants and those who are in the formal private sector. So there are 3 schemes in Thailand. China has a similar model to Thailand's. It used to have 3 schemes, but now it has 2 schemes. There's a separate scheme for employees and another one for, by employees, I mean formal sector, non-employees, meaning the self-employed, informal sector. But even though these are separate schemes, they're administered by a single agency. So I just want you to keep in mind as you're listening to these different options and different models, because what is the relevance for India? So in China's case, for instance, you can say that they have consolidated these 2 different schemes, but they've not entirely integrated them. So the single agency that runs these schemes is like the NHA of India, but the schemes are not integrated in terms, they're not sort of, the funds are not integrated, but the same agency runs both schemes. Brazil is very similar to the model for Sri Lanka and Malaysia. You have a very decentralized tax-financed universal public system, but rather than having out-of-pocket spending for the rich and the well-off, it's a lot of private insurance for the well-off. There is out-of-pocket spending also, but there's a lot of private firms provide you coverage through private schemes, and so it's sort of a more advanced version of the Sri Lanka Malaysia model. I'm not going to go through all of these, but these are just notes for those of you who want to learn a bit more about Brazil, about China, about Egypt, about Indonesia. The basic point is there's no one universal way to get to universal health coverage. All countries have used some element of public financing to expand coverage, but the way in which that public financing is structured varies. So in some cases, it's tax finance, some cases it's a combination, some cases they have separate programs. There are pros and cons to each one of those, and different countries are at different levels. So these are just sort of very short notes for those who want to take a look after the presentation to get a sense of how different countries are doing. And for those who are more interested to find out more details, I'm happy to provide references. So Philippines, Russia, South Africa, Thailand are typically countries that we study to try and understand how is it that they're trying to get to universal health coverage. One big challenge that's very common in developing countries is, including in India, which merits some extra attention, is how do you cover the missing middle of the population? And this missing middle basically means that in many countries, you have the poor who are covered by tax financing, including like in India, the rich and the well-off, the formal sector that are covered by formal insurance, but the non-poor informal sector gets left out because they're not poor enough to be covered by these non-contributory schemes like PMJ, but also they're not in the formal sector, so they don't have access to these other things. So if you take a look at, for instance, the example of South Korea, South Korea has a social health insurance modality, which was enforced in 1977, and almost 100% of its population was covered by 1989. Covered either because they were paying themselves or the government was paying the premium for you. But what helped Korea a lot was during this period, there was a very rapid decline in informality when Korea grew. So because the decline in informality occurred, it became easier and easier to collect mandatory contributions from the formal sector. What's been happening more recently, in particular since the 80s and the 90s and so, and if you take a look at the Indonesia case, Indonesia has a similar model. Indonesia started with the health card for the poor, which is a bit like PMJ, but has still not attained universal health coverage, partly because levels of informality not only in Indonesia, but in many other countries have not declined as much. So if they use a social health insurance model, it becomes very difficult for them to collect contributions. And so that's been one of the challenges, the high levels of informality. How do you cover the non-poor informal sector? And if you take a look more specifically at Indonesia's case, the top 30% of the population is covered by social health insurance, where the mandatory contribution taken out of payroll. Bottom 40% is covered by the government, but you have a missing middle of about 30% who don't have jobs that allow you to have payroll and things like that. So it's very difficult to mandate them to purchase the social health insurance program in Indonesia, which is called JKN. It's a single program that covers everybody. It used to be different programs, but it's now a single program. And in many ways is a good model to look at for India, because in India's case also you have the bottom covered with PMJ, you have the top sort of 20% of the population covered by CGHIS and other schemes, but you still have a large missing model. And I'm just also giving you an example of a payroll statement from Indonesia. The name has been blocked out, but you can see that this is the salary of the person. Indonesia's currency is called the rupiah. It's the same name as the Indian currency's name, but you can see that BPJS Kesehatan, this is their NHA. Kesehatan it's actually from Sanskrit, Sehat. That's the name of the agency, and this is a mandatory contribution. It's a certain percentage of your payroll that gets deducted for the top contributory part, just to give you a sense. The other sort of key lesson is that, you know, some form of compulsion and redistribution is really necessary for universal health coverage. It has to be compulsory that you prepay either through general taxes, because you have to pay taxes, or through this mandatory earmarked payroll tax. So many countries that have tried to get revenues from the non-informal sector in exchange for health insurance coverage have struggled and have failed because of what economists call adverse selection. Usually, if you don't make it mandatory, only the sick sign up for insurance, and that creates a problem for the health insurance fund. The bottom point is you need also the healthy to prepay into a pool so that you can have risk pooling. And then if you also have the poor in the same pool, you can also use those prepayments to subsidize the premium payments for the poor. So compulsion and redistribution are necessary for countries to make progress towards universal health coverage. Some compulsory form of prepayment for those who can prepay, and then redistribution for those who cannot prepay. And this is what some countries have done for covering this missing middle problem. Some have actually given up. They abandoned completely SHI financing. Brazil, UK, Norway, Denmark, a whole list of countries gave up trying to collect contributions from everybody, moved to a tax finance or a hybrid tax finance model. Others extended fully subsidized coverage to the non-poor informal sector, like in Thailand. Also, some have universalized specific services. A small package is made universal that everybody has access to, regardless of your insurance status. And then other services, you can then have additional coverage. And then in other countries, there's been a delinking of contribution to entitlement. So Russia and Kazakhstan and other countries, including Egypt, use many, many different revenue sources. Some of these are earmarked taxes on income. Some of these are sin taxes, other general taxes pooled together, but the entitlement is universal. Let me just end briefly with some lessons and implications for India. So in India's, you know, if you look at India's UHC reforms, prior to PMJ being introduced in 2018, you had many different sort of small schemes. You had, for instance, the National Health Mission that provided primary care. tax-financed access, emphasizing more the rural areas. You had ESIC, you have CGHS, and so on and so forth. And then in 2018, you had this massive PMJ program building on RSBY and other state programs that was introduced, which became the largest government funding program, coverage of more than 10 crore families, benefit coverage, primarily for inpatient care, with both public and private hospitals empaneled. So given that this is where we are now, how can now we think about making progress towards universal health coverage? I'm just going to give you some thought experiments here, just to stimulate discussion. One point to make is that PMJ is actually an excellent platform to accelerate universal health coverage in India. It's got already so many hospitals empaneled, so many households. It's almost covering the entire country. It's a very sort of well-oiled machine in terms of being an IT-driven process flow. So it can make a great foundation over which it can go beyond just providing inpatient coverage for the bottom 40% of the population. And just a couple of ways in which you can expand, think of expanding PMJ using NHA. You could, of course, expand to cover additional people. In fact, some states are already doing that. So you can cover informal workers, the non-poor informal workers. You can try to cover the missing middle. You can use some other income-based criteria to get in the near poor. So one model that's already being followed in some states is to really use it as a vehicle to expand to more and more people. The other thing that could be done is you could expand benefits that PMJ provides. So you could include outpatient care, you could include outpatient diagnostic services, you could include all of primary care services, just as it covers now hospitalization and surgery and things like that. You could expand benefits. You could make it a vehicle for converging different schemes. By converging, I just mean that it like in China, NHA and PMJ give a platform, but different schemes can be administered through using the same mechanism. So already there are steps towards convergence with for CGHS and ESIC. Those are very important foundation that can be done to implement in the future integration. By integration, I just mean taking the convergence to the next step, where even the pooling of funds and the benefits package become unified, so that you can move towards a one nation, one scheme kind of a model, like Vietnam, like Indonesia, like Philippines and others have done, where you then end up having a unified strategic purchaser of services with an integrated digital backbone and a unified benefits package. Here we have just done some back of the envelope calculations that, for instance, if you, instead of using the SECC, you ended up using the NFSA to target India's population. Already this has been done by several states. Currently under PMJ, you would move from 40% to 63% of the population who would be eligible to be classified as poor and near poor. If the premiums are the same, what might the implications be for the budget? We've done some calculations. You could, of course, keep going and then cover all those who are uncovered. So leaving out those who are covered with CGHS and ESIC, cover everybody else, and so on and so forth, to try and see how many more people would you cover, how much outlay there might be, how could this be financed. This is just keeping the benefits package the same, but simply expanding population coverage, as has been done by many countries in the past, would be one way to think about expanding to universal health coverage. The other way is to expand the benefits package. So don't just leave it at inpatient care, but you could also include other outpatient care services. We know that in India, a large amount of out-of-pocket spending is due to outpatient care and cost of medicines. Already in some states like Tamil Nadu, they have diagnostic packages and outpatient packages at the private sector that are included. Of course, this is, my colleagues tell me that this is technically challenging, given that now you'll have so many more providers. But I tell Sheena, isn't it challenging if you're poor? isn't that a challenge also to access diagnostics and medicine? So let's not forget that we're doing this for a public good, and the challenges may be immense technically, but there are also challenges from a humanitarian point of view that we should keep in mind. And it could begin by just perhaps empaneling a small set of private providers that will provide outpatient services. And just as PMJ gives additional financing to public hospitals, PMJ could also begin to give additional financing for NHM when primary care services are accessed. And of course, I've already mentioned one thing. In addition to expanding the benefits package, you could use PMJ to converge with other schemes. Eventually also with integration potentially with other schemes, where you may end up with a system with a unified benefits package with different ways in which people contribute. So those who can should be mandated to pay the premiums. Those who cannot, the government should pay for them. And the missing middle, we can use some version of what other countries have done to try and get additional resources. So these are just some thoughts to make you think forward as to how do you move forward in the universal health coverage journey of India while taking lessons from others and also teaching others on how you could do it. The basic idea is then potentially one model would be to just take PMJ and use it as a vehicle to expand to more people, to more services, and to also reduce out-of-pocket spending. Of course, all of this is going to require more revenues, and these are just some questions. I think this is more for discussion. Ideally, you would want to have expansion, especially for the poor and near poor, by increasing health's share of the government budget. In India, health gets a very small share of the government budget compared to other countries, and especially small at the state level. The average globally is about 11% of the government budget going to health. Ideally, we would want that to happen through some sorts of general tax financing. You may recall that when PMJ was introduced, India also expanded the cess on education, made it the health and education cess, although it's still not completely clear whether that 1% additional cess directly goes to PMJ, but at least it was used as an excuse to raise taxes. So there's a 1% tax on all taxes paid additionally that was added when PMJ was introduced. Of course, there's a disadvantage cesses have, that these are proceeds that can't be shared with the states. So this would actually create some additional distortion. So we need to have a mechanism by which this perhaps not a cess, but some sort of a similar tax could be introduced that's shared between the center and states. Some countries have very cleverly used health taxes. So they've increased taxes on alcohol, tobacco, sugar sweetened beverages, and used it as an excuse to expand coverage. And the most celebrated example of that is the Philippines, which introduced additional taxes on tobacco and alcohol, and they used those taxes to pay the premiums for expanding universal health coverage. So sort of very clever sort of mechanisms with the same objective. Again, the key point is to make sure that whatever you do is adequately financed and predictably financed, and to make progress towards universal health coverage. I'm going to end here. I think I went a little bit over. Apologies, but I'm going to hand it over to Sheena to take us forward in terms of further discussion. Over to you, Sheena.
Yeah, Ajay, can you have the next slide, please? The last slide that we had. The last one, yeah, thank you. If you can have that on the slideshow mode, thank you very much. I think, in the interest of time, I'm going to make my comments very, very brief. One thing which was abundantly clear in terms of from the presentation that Ajay had was that UHC is really a journey and not a destination. So you can't say I've arrived at UHC. I think that's not what this is about. It's also very clear that different countries have taken different paths. And also, while they have been on a course, they have also made adjustments in terms of how they want to move towards UHC, looking at the learnings. However, irrespective of whatever path they may have chosen, I think the objective remains common, in terms of how do you get people to have effective access to services that they need, when they need them, and without any financial hardship. So I think that remains the three dimensions of UHC that Ajay alluded to. And as policymakers, I think the key question that confronts is, how do you get more and more people covered? How do you include more and more services that are part of the coverage, and how you actually reduce the cost at the time when you are accessing services, how the out-of-pocket payment cost can be reduced. I think these were some of the key messages that we heard up till now. One other thing which becomes very abundantly clear, if we look at all the global examples that Ajay alluded to, that public financing is key for UHC. And there's a lot of discussion that we've had around, how do you reach the missing middle, how do you go beyond the 40% of the population that is covered by PMJ? And we've also seen, how the importance of that really voluntary contributions don't really work. I think that's one of the lessons that we have had. There is, what Ajay, the phrase that he used was compulsion and redistribution is something which is very important, because many countries have looked at collecting revenues from the non-poor informal sector, and none have really managed to do that very successfully, and what really happens is, unless you have one finds that if you make this voluntary, there is adverse selection, there is low uptake, unless you have a very large premium, in terms of you subsidize that premium significantly, you don't find that there is that traction that's there. The other aspect is what we've also seen countries that are attempting to look at, whether we look at Philippines, whether we look at Indonesia, whether we look at Vietnam, when they are looking at reaching the missing middle, there's also, the total government budget accounts for about 6 to 8%. India is at about 4% of public resources. And that's something which does need, that needs to be expanded. And that really raises the question in terms of, if we look at, is there that room, fiscal room that is available for expanding coverage? Especially, as we look at this as a state subject, that there is a, in terms of, even with PMJ, 60% of the contributions may be coming from the, in terms of the federal, but then there is 40% that needs to come from the states as it is. So is there any fiscal room that's available for expanding the population coverage? Is there any fiscal room that's available for expanding services? I think that becomes a very important question. And this becomes a question, especially for poorer states like Bihar and Uttar Pradesh, in terms of where is that space that's available. And this further gets compounded with the fact that because of COVID, the economic impact that COVID has had, how much room there is available for that. I think that's one issue. The other issue that we've seen, and I think that's another very important learning that we have seen in terms of the different countries, that you don't sort of really make it universal. It's really a journey which you transfer over, many years and decades to be able to provide universal coverage. It has to be done in a phased manner, and part of that phasing also comes in terms of really, one is the resources that are available. The other big question is in terms of the implementation capacity. If we look at implementation capacity, and I think since we have the entire target audience here, which is at the helm of really implementing various efforts at the state level, we know that even a lot of the brownfield states are struggling with implementing PMJ, and the capacity is limited. So given all of that, how do we look at low-income states which are not performing that well? How realistic it is for us to expand coverage beyond the 40% currently? And also in that context, if we look at inclusion of outpatient packages, which will also mean, in terms of different sets of providers will need to be brought in the fold, in terms of management of those providers and providing outpatient package, how much, what that plan and that journey is going to be. I think that is another very important aspect in terms of implementation capacity. We also know that in terms of supply side readiness, whether we look at diagnostic, whether we look at outpatient coverage, we look at availability of hospitals in tier 2 and tier 3 cities. On the supply side, the kind of stimulus that needs to be given for expanding the benefits. I think that again is something which is challenging as we look at the journey of expanding PMJ beyond 40%, beyond also looking at beyond hospitalization care. So these were some of the areas which we thought would be good to really discuss, and I know that these are not the discussions that we're going to have today, but some thoughts as we think through this journey of universal health coverage in India. So with that, I'm going to hand over to Sudha.
Thank you, Sheena and Ajay, for a very detailed presentation and also providing the latest updates. I think we have Dr. Kelkar, who has raised his hand. Dr. Kelkar is the CEO SHA, Kerala. Sir, please go ahead. We're not able to hear you. Should I?
Dr. Kelkar, please unmute yourself.
Sorry, was I supposed to say something?
You had raised your hand. So we thought you had a query.
Did I raise a hand?
Yes.
Okay. I don't know. I don't seem to have raised my hand, at least in my screen. Okay. I have nothing, to ask. The presentation was good. And as pointed out by Ajay, we are also looking at plugging the missing middle. And like you rightly pointed out, there are umpteen number of schemes which are being run by the various line departments. So we are looking at converging all of them. So in the next 6 months or so, we are looking at converging 5 or 6 schemes of social sector department, the social welfare department, and also the labor department. So that is one thing which we are planning to do in the next 6 months. And at the same time, like you pointed out about extending the services to other categories. Unlike SECC data, which is used currently in PMJ, NFSA would probably be ideal. But nevertheless, Kerala has already covered, at least 95% of the NFSA personnel as well in the existing scheme itself as a state component. So if the NFSA would be coming into action, definitely there'll be more funds coming to the states, which will definitely be useful because the states are currently having a resource crunch, and any support from Government of India would definitely be welcome. And the good practices that you mentioned about making outpatient and diagnostics available to all categories as a general principle under the free diagnostic services of the NHM. The diagnostics in all the public health systems are more or less free for everybody, irrespective of the income groups. So to that extent, the out-of-pocket expenditure is likely to reduce because these free diagnostics also takes into account some of the routine diagnostics as well as the high-end diagnostics of CT, MRI as well. So to that extent, the out-of-pocket would definitely come down. But what the trend we are finding in Kerala is, irrespective of or in spite of all these efforts, there is still a high out-of-pocket expenditure as is being shown. Probably the outpatient now could be one reason why uh, the people are preferring, in Kerala, there's a lot of focus, the lot of private hospitals in the district. So the people generally access private healthcare for outpatient services. So that could be one reason why we have a lot of out-of-pocket expenditure. But like you rightly pointed out, there's a lot of investment going in from the Ministry of Health in terms of upgradation of the frontline health institutions like the sub centers, taluk hospitals, the district hospitals. There is a lot of focus on the OP transformation itself, so that a basket of services is assured to the people when they land there, and the good quality of services also being emphasized upon. So in the coming days, I'm sure the out-of-pocket is likely to come down because the public health infrastructure would be very good across the country, wherein the people will find good quality service very close to their doorstep. So with that in mind, I think the out-of-pocket is likely to come down, but still a long way to go for India as a whole when you look at the UHC as a concept. Now, because there are a lot of legacy, projects and programs, a lot of legacy issues in IT systems. One of the points you highlighted was a very robust IT system. Probably the Ayushman Bharat digital mission can replace that middleware which is missing currently in all the states. So I think a lot of convergence is needed, and in a diverse environment like ours, it becomes that much difficult to move forward, taking on board the states, the various departments, and various stakeholders. But nevertheless, a good a start has been done by bringing in PMJ as well as NHM now focusing on the health and wellness center concept, as well as on the 15th Finance Commission grants has come in a big way, wherein the urban and the rural infrastructure is going to be improved drastically in the next 5 years. So hopefully your presentation will undergo a transformational change the next time you present, based on the inputs which are likely to come from the ministry in the next few years. Otherwise, a wonderful presentation, a lot of takeaways for me especially, and we will try to work on some of the guidance that has been provided in the presentation. Thank you.
Dr. Amit and Dr. Alok, please. Please introduce yourself and share your questions or comments.
Good morning, ma'am. Thank you so much for the lecture. It was very wonderful. Myself, Dr. Amit from Rajasthan, ACO, Arsha. In Rajasthan, we have also gone for this universal health coverage. Almost 75% people are covered under the scheme right now. But and the rest of our government employees and private health insurance public, we are trying to maximum incentivize the local functionaries to more and more register the beneficiaries. Given incentive of 100 rupees also per family registration. But still there are some issues that we are facing, like how we could cater to these, like despite saying prior 5 days charges would be covered under it, but still that's the issue with the government hospitals even also, because their accounting principles and these, like they are not able to the refunds. Like in AIMS Delhi, I see very uniquely, like after the beneficiary shows his cards, there will be free treatment for every aspect. But like in AIMS Jodhpur, there is entirely different practice. They give free treatment only after the pre-auth approval for that specific package. So instead of hospitals providing free treatment or to the covering whole aspect, they are just catering to that specific illness. That's for the even public hospitals. And regarding these OPD testings investigations, that is very tough to cover with both aspects of fraud perspective also, like open investigations, leaving scope, that raise the scope of this investigation also. These 2-3 aspects, how we could cover in the long term, that would be very helpful. Ultimately, patient is bearing the cost for that. And we are not able to help out in reducing the out-of-pocket expenditure for the beneficiary. If any inputs over that would be very welcome.
So, Dr. Sudha, should I respond?
Yes,
Take
yes.
two at a time. Yeah. No, very
Yes.
very good points by Dr. Kalkar and Dr. Amit. Yes, you're right that with NHM. The Ayushman Bharat, the Health and Wellness Center reforms and inclusion of NCD packages at the frontline services that should help quite a bit. Take away some of the utilization, because still the instinct of most of our population is to, especially.
Ajay, you gone on mute, Ajay.
Can you hear me?
We couldn't hear
Yes.
the latter part. Yeah.
Somebody seems to be muting me. Is it?
No.
It's okay?
Yeah.
Okay. So yeah, as part of NHM, just having a strengthening provision of diagnostics, of medicines, especially at the frontline level, I think is very important because I think the system is muting me. It wants me to keep quiet. So it can help in terms of reducing out-of-pocket spending, and also with growing chronic care, right? The NCDs are now the dominant source of the burden of disease. So chronic care, I think we have to remind ourselves that it's, somebody who has diabetes or hypertension or something like, they're going to have this for 50, 60, 70 years of their life, meaning out-of-pocket spending is going to be always there. It's not like acute care, and so even more important to not create any barriers. And again, let's not think about people like us. Let's think about the poor and those who are struggling. How would they access? So as long as NHM is bolstered, that can help. But also it requires integration between, I think, as Dr. Amit was pointing out, that currently the hospitalization package being different from the primary care, which is available at NHM, that creates barriers. So ideally, you actually want those to be integrated. It helps the system more generally, and also in terms of, so you're not only focusing attention on hospitalization, but also during sort of more routine thing. And in fact, some of the things that we're looking at in is also globally looking at, Dr. Sudha can tell you, looking at what share of hospitalizations is due to ambulatory care sensitive conditions, again, to make the link that what happens in primary care matters. So if you have very good primary care for diabetes, for hypertension, for COPD, your hospitalizations for those conditions should not exist. Same for dialysis. So yes, currently, because we've had that problem, but over time, strong primary care should reduce the need for dialysis, for hospitalizations, for NCDs. And unless you integrate the packages together, that's going to always be a bit of a challenge to do that. And where sort of in urban areas and other areas where your NHM, your structure of sub-centers and all is not well set up, to perhaps augment it by including some private providers where there's a capacity problem in the public sector, to do the same thing like you do for the hospitals is what I was meaning, not as a replacement, but just to make access easier. So we want to make it as easy as possible. Currently in India and Indonesia and Laos, the first point of contact for a lot of primary care like services is becoming the private pharmacy, and that's also a very worrying trend with antibiotic resistance and things like that. So we need to reverse this and go back in the right direction. Thanks.
Thanks. Just to add on in terms of the diagnostics, what NHA is currently also working out to reduce the diagnostic out-of-pocket expenditure, at least for the covered conditions and the packages, is to also develop the e-rupee vouchers. So that if the hospital does not have the facility and when they refer them out, then they have no control over even though we pay the package to the hospital, some of the diagnostics get done in an external setup, and there is no way of ensuring the reimbursement and working out mechanisms to reduce or pay back to the patient. So in that sense, we are looking at this e-rupee voucher, which is a work in progress. So we might be piloting it quite soon. And diagnostic packages we have considered from the CGHS. So we will try to start up with what is available under the CGHS diagnostic list, and then work up, for specific further, required conditions. So that is one thing. And are there any other questions anybody wants to just, you are free to unmute before we, close. I know we have extended this session, but it is quite important that, when we have the participation, to ensure that everyone has a chance to clear up or raise queries. So the floor is still open if anyone wants to take the last call.
Yeah, thank you. Thank you, Dr. Sudha. So, Dr. Sunit this side from CB Division NHA. Sir, I would like to ask two questions very quickly. One is regarding you focused and you explained the whole concept of including missing middle. So there is one argument, and I remember like Dr. Sheena in this presentation as well, kind of gave me the clarification, the answer which I'm looking for. Uh, I mean, a charging missing middle, those who are above the ABPMGY beneficiary base currently, charging some premium, an annual premium, and then including them under the ABPMGY and then giving them services. Will that kind be a measure which can try to resolve the financial constraint of the center as well as the states to some extent? And my follow-up question is, in many studies, and we also studied this in our public health, that if you want to reduce out-of-pocket expenditures in true sense, you should also include the traveling, the transportation cost as well as accommodation cost as well. So I just want to understand these two questions. Thank you.
Yes, I can answer very quickly. So yes, if Dr. Sunit, if you're able to figure out a way in which you can get the missing middle, the informal non-poor to contribute, you're ready to get the Nobel Prize. Many countries have tried to do it. It's been impossible unless you have very strict enforcement. There's a variety of reasons. People think they're so healthy. The key point is for any kind of health financing system to work, you need the healthy to prepay also. What ends up happening is if you say, oh, please sign up, low premium and all that, it's still the sick who sign up. And that's called adverse selection. And if the sick sign up, that doesn't work. Then there's no difference between out-of-pocket spending and paying premiums. You actually need the healthy to sign up so that there's a risk pooling in health insurance. So that's the part that many countries have struggled with to try and get the informal sector to have a mandatory premium. So you have to make it compulsory, just as you have compulsory. Don't you have in India? Don't you have compulsory insurance for driving and things like that? It is, right?
Yes,
there's
yes,
a reason. There's a reason you need to have compulsory. Globally, it's compulsory. In Switzerland, it's compulsory to buy private insurance. In US, it's compulsory to buy private insurance. In other countries, it's either in the UK, you have to pay taxes and your entitlement is free. There's no insurance there. So the compulsion part is very important for getting this thing, because otherwise it just will not work. Some countries have said, let's put consumption taxes. So for instance, in Ghana, instead of taxing your payroll or your income, they put an additional tax on the consumption, and that's used to pay for social health insurance. So 2.5% of their GST, and everybody pays, ends up paying GST to some degree or the other. That's used to pay. But your instinct is right. You want the non-poor to prepay. but administratively, it's very difficult to force them to prepay. And that's why that's the challenge of developing countries. And yes, for traveling and accommodation costs, you're right, these are not direct. These are not what we consider direct out-of-pocket spending, but they are very important indirect costs. And in fact, many countries, in fact, even PMJ, right? Some of the packages do have some element of transport costs included. In many countries, for instance, in the UK, if there's some tertiary surgery that you're not able to get in your county, you have to travel to London or something like that, you do get reimbursed for your travel. Some countries go even further, that in fact, even in some cases in India, for preventive care and for delivering in facilities for ANC care, you actually pay the people. You pay them a small amount. So it's like a conditional cash transfer, and say, because to offset the lost wages, the travel. So in many countries, a small amount of payment is actually made to get children immunized, to have mothers come in for antenatal care. So yes, these are important considerations, especially if in areas and situations where travel costs and things like that become a problem. So these are elements of what we call the social protection dimension of accessing healthcare. But yes, an excellent point to consider, especially for the poor.
Thank you, sir.
One thing which Ajay, I think you alluded to, but I would just like to just make one brief point. Though in terms of we have looked at contributory, what Ajay is saying, we don't really have any global example. So if we really wanted to expand coverage to the missing middle, I think the lessons that we have currently are that make the entitlement universal, make it general tax finance, make it non-contributory. I think that's the lesson that we have globally that we can look at. So within that, looking at the fiscal space, you may decide that, okay, we can't have the full package of services that I can make universal, but it's this much package of services that I can make universal that I'm going to start with. Maybe a decision, and in a phased manner, as there's more fiscal room that's available with more experience and more implementation capacity, you gradually expand the package of services that's available. That could be one option that I wanted to put on the table.
Yeah. Thank you, ma'am. I think Malti ma'am wants to add something or ask something.
Yes, good afternoon, everyone. No, I just wanted to thank Capacity Building for organizing this master class by Dr. Ajay Tandon. It was really wonderful to hear him. And thank you to Dr. Sudha and Dr. and Sheena also. I just want to, share my, view that now that PMJ is already launched, that so people are comparing that PMJ covers, every secondary and tertiary care, to the point that we may offer limited benefits to all. Sheena, it may be politically not so convenient to do so now. Once you offer something to part of the public, then it becomes, a little bit challenging in that sense. But a wonderful masterclass, just like previous ones organized by Capacity Building by Dr. Shankar Prinja on health technology assessments. We really love these classes, and thank you so much for teaching us like a teacher. I would say thank you.
Thank you, ma'am.
Mr. Ajay, just last one question. In Rajasthan, in the tribal districts, government has given 95 to 98% people are under the health insurance. Apart from the primary care, there is no facility to provide the health care in that areas. So ultimately, government is paying insurance for those people, but the utilization of the health facilities is very low because of the low accessibility. We have tried to go the relax the criterias, but ultimately, since there are no good health facilities, we are not able to empanel, and they are not able to access these services. So like earlier question discussion on transport services, how some incentive model or something could be devised so that people can come to the urban areas or those who have the good facilities. So ultimately they could be benefited. Otherwise, that's giving the premium or paying for on their behalf is not giving any benefit. Any comments?
Yeah, no, that's a good point. In fact, in many countries, before they roll out insurance, they make sure that at least there's good supply. I think that's the point that Sheena was making in her last slide, right? That it's not just about giving premium payments. You have to also make sure there's supply, either the public sector or using public financing to access the private sector. So the key is to make sure the service is available. This is, I mean, it happens in many contexts, especially for high-end tertiary care, right? I mean, for primary care, you still have options of using mobile clinics or perhaps some element of telecommuting or some kind of incentives given to provide outreach services. But for tertiary, high-end secondary and tertiary care, you need to take the patient to the services. And yes, in many countries, that's explicitly part of the package is that you offer transportation services and also to raise awareness among the beneficiaries that this is something that you can avail and you have access to. I mean, you're talking about tribal districts. I mean, we work in countries where there's not a single tertiary hospital in the entire country. So one of my countries that I study is Bhutan. They have not a single tertiary hospital. Not only do they have to go out of country. So same is in the case with Maldives and other places. So similar challenges. Where sometimes some kind of a package just for accessing remote areas is developed by also giving some additional financing to make it clear that you have services covered and to be very proactive in terms of implementing that. In the absence of being able to provide those services nearby, there is no other option but to have some mechanism by which this transportation is conducted.
I would just like to add that some of the northeastern states already do, because they don't have tertiary care hospitals, and they do, for cancer treatment and for, serious, ailments. They already have arrangements. They even pay for flying the people. Yes,
exactly.
Yeah. No, the National Tuberculosis Program had a facility of giving this transport amount to people when they come to pick up the medicine. So there is a precedence probably that has to be implemented.
Thank you so much.
Okay. Thank you so much, sir. So now we come to the end of our presentation, our session. I would like to thank Dr. Ajay and Sheena ma'am for delivering such an insightful and such a comprehensive presentation today. And it was not just very much informative. We got to learn and see a lot of concepts and factors affecting UHC. And it's not just like UHC is something which you can provide, but there are multiple factors which really affect this whole UHC implementation. And as ma'am rightly pointed out during the session, that it's a journey. So thank you so much, sir. And I would also like to thank Dr. Sudha as well for moderating the session. And thank you to all the participants who have joined today.
Thank you. Thank you very much.
Thank you.
Thank you, Sheen.
Have a good rest of the day.
Thank you, everyone.